Hello everyone, today we are going to talk about Immune Thrombocytopenic Purpura, which is also known as Idiopathic Thrombocytopenic Purpura or Immune Thrombocytopenia. So, thrombocytopenia means a decreased number of platelets in the blood. Purpura means a purple discoloration of the skin, like in a bruise. Immune Thrombocytopenic Purpura (ITP) is a rare autoimmune disease that results in the low platelet counts. So what are the platelets? Platelets are the cell fragments that are found in the blood, and their function is to help the blood to clot. Thus, low platelet levels results in the increased risk of bleeding and bruising. Antibodies are produced by cells of the immune system, and they normally help fight the infections. The immune system normally recognizes self-antigens and doesn't attack tissues or organs of the body. But in ITP, platelet autoantibodies, usually IgG, are directed against the glycoprotein 2b3a or 1b complex on the platelet's surface. Platelets become coated with autoantibodies and thus results in the premature removal of platelets from the circulation by macrophages of the reticuloendothelial system, especially the spleen. The average lifespan of a platelet is 10 days in a healthy person, but in ITP, the platelet lifespan is reduced to a few hours. It is a type 2 allergy because it involves antibodies. So what causes ITP? The cause of ITP is not known. It is usually idiopathic but may be seen in association with other diseases such as SLE, HIV infection, hepatitis C infection, Helicobacter pylori infection, and etc. It is also thought that viral infections might make the immune system become overactive and start producing abnormal antibodies. We call it primary ITP when the ITP is not associated with another disease. And we call it secondary ITP when it is associated with another disease. For example, autoimmune diseases such as SLE and chronic viral infections such as HIV or hepatitis C, and primary immune deficiency or certain medications or cancer. The two categories of ITP are: acute ITP usually affects young children, especially those between 2 to 6 years old. Acute ITP accounts for 90% of cases of ITP. Acute ITP may follow vaccination or a viral infection such as the mumps, chickenpox, or the flu. They often get better without treatment. In adults, the disease often lasts months or years, thus called chronic ITP. Chronic ITP has similar symptoms to acute ITP, but it lasts for longer than 6 months. Even though it is seen more in adults, some teens and children also get this type of ITP. Chronic ITP tend to relapse and remit spontaneously, so the course is difficult to predict. So what are the risk factors of ITP? ITP is more commonly seen among young women. The risk appears to be higher in people who also have other autoimmune disorders, such as rheumatoid arthritis or SLE. Next, let's see the symptoms of ITP. ITP may not have symptoms, but if the platelet count drops very low, they may experience an increase in bruising or bleeding because of the tendency to bleed. And the symptoms of ITP may include fatigue, as it is a common symptom in ITP. Because of the lower platelet counts, you will have easy bleeding and bruising, so you may see small red bruises, which are called petechiae. And they do not go pale with pressure as they are the tiny bleedings into your skin. They may look like a rash. The bruises mostly show up on your lower legs. You may also see bleeding into your skin that's larger than petechiae, and it's known as purpura. This is how the disease got its previous name, Idiopathic Thrombocytopenic Purpura. Additionally, bleeding of gums or frequent nosebleeds, as well as menorrhagia, which means excessive menstrual bleeding, may be seen. You may also see blood in urine or stools. In severe cases, you may see a spontaneous formation of hematomas, blood masses in your mouth or on other mucous membranes. Also, bleeding time for minor lacerations or abrasions is usually prolonged. In cases where the platelet counts drop to extremely low levels, potentially fatal complications may arise. They include subarachnoid or intracerebral hemorrhage, which is bleeding inside the skull or brain, lower gastrointestinal bleeding, or other internal bleedings. Even though the platelets are destroyed by splenic macrophages in ITP, the spleen is normally not enlarged. So if you see an enlarged spleen, you should think about other possible causes for the thrombocytopenia. The diagnosis of ITP is a diagnosis of exclusion. So once a low platelet count has been discovered, more tests are used to rule out any other causes. These tests may include blood tests, such as a full blood examination to check for blood counts. In ITP patients, you may only see a decrease in the platelet numbers, but no other abnormalities in other cell counts, unless there is iron deficiency anemia due to blood loss. Other blood tests that may be performed include viral for hepatitis and HIV, and autoimmune for lupus or rheumatoid arthritis, and also checking blood clotting tests, for example PT, IPTT, and vitamins and iron levels. In ITP, the bleeding time is prolonged as ITP is a platelet disorder, but PT and IPTT is normal. All patients with presumed ITP should be tested for HIV or hepatitis C, as platelet counts may be corrected by treating the underlying disease. They may also do other tests in order to rule out other conditions that may cause a low platelet count, such as acute leukemia and aplastic anemia. The blood film shows reduced number of platelets, and the platelets may often be large. The platelets may be large because the platelet turnover is increased, and there are no abnormalities in other cells. Anti-glycoprotein GP2B3A or GP1B antibodies are also detectable on the platelet surface or in the serum in most patients, and these tests are sensitive. Bone marrow biopsy is not required to diagnose ITP, but may be performed to rule out other problems. In a person with ITP, the platelets produced in the bone marrow should be normal, and you may see normal or increased number of megakaryocytes. Megakaryocytes are the cells that make platelets. As the platelet counts are low in ITP, the megakaryocytes may increase as a compensatory mechanism in an attempt to make more platelets. There are also cases with normal counts of megakaryocytes. So what are the treatments for ITP? People with ITP who don't have symptoms or whose platelet count isn't too low might not need treatment. In some cases, ITP goes away by itself. But in cases where the platelet count is very low or has symptoms, treatment should be started. The treatments for ITP include corticosteroids. Steroids are considered as first-line therapy for ITP, on which 80% of patients remit. Steroids are used to reduce the activity of the immune system. Monoclonal antibody rituximab, which is anti-CD20 antibody, produces responses in about 80% of patients, and it is now usually tried before splenectomy. Thrombopoietin receptor agonists are also used for patients in whom steroids are contraindicated or who are refractory to steroids. Thrombopoietin makes the bone marrow produce more platelets, so thrombopoietin receptor agonists stimulate thrombopoiesis, which means production of platelets. Splenectomy, which is surgical removal of the spleen, is considered in patients who are either unresponsive to steroid treatment or have frequent relapses. Platelets, which have been bound by antibodies, are taken up by macrophages in the spleen, and so removal of the spleen reduces platelet destruction. Splenectomy is potentially risky in patients with ITP because of the increased possibility of bleeding during surgery. The immunosuppressants, for example vincristine or cyclophosphamide, are usually reserved for those patients who do not respond significantly to the above treatments. Other treatments include danazol, or intravenous anti-D immunoglobulin, and it's often necessary to combine two drugs, for example danazol and other immunosuppressant. If present, we should also treat H. pylori or hepatitis C, as it is reported that it may improve the platelet count. Platelet transfusion. Platelet transfusion alone is not normally recommended except in an emergency, and it is not beneficial for a long-term platelet count increase. Because in ITP patients, donor platelets will also be destroyed by the splenic macrophages. And in some severe cases, stem cell transplantation may be effective. High-dose intravenous immunoglobulin therapy is particularly useful in emergency settings, such as patients with life-threatening hemorrhage and patients during pregnancy or prior to surgery. It is also useful in steroid refractory cases. This treatment is able to produce a rapid increase in the platelet count in the majority of patients. So the platelets, which are bound by antibodies, are taken up by macrophages in the spleen, and those macrophages have Fc receptor. So the mechanism of action of intravenous immunoglobulins might be because of the blockade to the Fc receptors. So it lessens the destruction of the platelets by the spleen and thus results in the rapid increase in the platelet count. If you want the notes, you can download them from the link in my description box. So let's review immune thrombocytopenia. So ITP is an autoimmune disease in which the antibodies attack the platelets, resulting in a low platelet count and thus having an increased risk of bleeding. Primary ITP is when it's not associated with other diseases, and secondary ITP is when it's associated with other diseases. Acute ITP is common in children and it follows a vaccination or virus infection. Chronic ITP is more common in adults and it may be longer than 6 months. The symptoms include fatigue and easy bruising such as petechiae and purpura, and also bleeding from nose or gums or excessive menstrual bleeding. You may also see hematomas in the mouth or other mucous membranes. And if the platelet counts are too low, you may see fatal complications such as internal bleedings and subarachnoid or intracerebral hemorrhage. The diagnosis is by diagnosis of exclusion, so you have to rule out other causes. The platelets may be low, but there's no other abnormality in other blood counts. And blood clotting tests and vitamins and iron are also normal, and there should be no other causes, and all the patients with ITP should be tested for hepatitis C or HIV infection. In the blood film, there will be decrease of platelets, but no other abnormalities in other cells. There is also a specific test which can detect anti-glycoprotein GP2B, 3A, or GP1B antibodies. Bone marrow aspiration may show normal or increased megakaryocyte count. And the treatments include steroids, rituximab, thrombopoietin receptor agonists, splenectomy, immunosuppressants such as cyclophosphamide, and intravenous immunoglobulin for emergency times. And you should treat H. pylori or hepatitis C if present. That's it for today. If this video was helpful, please like this video and please subscribe to my channel. It would be very helpful. Thank you very much for listening. See you in my next video. Bye bye.